Hi everyone, welcome to this evening's webinar. My name's Helene and my colleague Jade is alongside me and we'll be running the webinar this evening. We're based in Geelong and it's been a warm day here. I'd like to begin by acknowledging the traditional owners of the land in which we meet today. I would also like to pay my respects to elders past and present. So welcome everybody. Just a little bit of PHN news. Just to let you know that the majority of our webinar events are recorded and freely available on our PHN Learn YouTube channel. We do have a practice communique we send out to all practices fortnightly, and there's some really good events on that. There's an external calendar of events and an internal calendar with all our events on it. For this evening's meeting, participants attending will be put on mute for the course. And should you have any questions, please type them in the questions box and they'll be answered during the, they'll be answered at the end of this webinar actually. And it'll all be anonymous, so I'll ask them on your behalf, but I will not mention any names. Our presenter for this evening is Dr. Elizabeth Farrell, gynaecologist. And I'd also like to acknowledge the Jean Hales organisation for the input into this event. Please make note of the West Vic PHN health pathway relating to this topic that is on the screen at the moment. I will hand over to Jo from our health pathways team to speak on this slide, and then we will go directly to our presenter for this evening. Thanks, Jo. I'll now hand over to you.
Thanks, Helene. Good evening, everyone. I'm Jo Rose, and I'm the Health Pathways Programme Officer at Western Victoria Primary Health Network. I'm going to provide a brief introduction to the endometriosis pathway on our website. For those unfamiliar with Health Pathways is an online clinical platform designed to support primary care clinicians. It contains many locally agreed condition-based guidelines and local referral information. Pathways are written by clinical editors in collaboration with specialists, subject matter experts, peak bodies and agencies, according to best evidence and in consideration of the local context. Health Pathways now has over 800 clinical referral and resource pathways available. You'll see on the slide a sample of the clinical and referral pathways that are relevant to this evening's contents. The login details to access Health Pathways have been provided in the chat threads and are also available in the Health Pathways handout. This is a generic login that can be used for all of your healthcare team. However, passwords are only provided to general practitioners, health professionals, and key primary care staff in the Western Victoria region, as the site is not designed to be accessed by the general public. If you have any questions regarding Health Pathways, please feel free to email us at healthpathways@westvicphn.com.au. I'll now hand over to Elizabeth. Thank you for your time.
Good evening, everyone, and thank you for being available this evening. I'm going to talk to you on endometriosis, a clinical update, diagnosis and management. I would also like to acknowledge the traditional owners of the land on which I am and to pay respects to those past, present and emerging. My disclosure statement is that I'm a speaker, consultant and on advisory board member for Pfizer, Vifor, Bessans and Theramex. So I'd like to present just briefly to start with a little case study of somebody who would often present to us with and ending up having endometriosis. So this lass is 21, she's a university student, and she comes to see her GP with severe dysmenorrhea and back pain. And this is the 6th visit since she was age 17. And this time she's coming because pain is increasing, yet she's on the pill and she's had recent onset of dyspareunia. And her mother's very worried because she's taking more and more time off her studies and she's finding that the normal pain relief that she has is not working. So this is a classic story, and let's work through our argument about what we should be doing with someone like her. So published in 2006, there was a qualitative study of women with period pain, and this shows us how the community and us as health professionals have not been really cognizant of what period pain really means. So the top quote is from a woman who basically said, well, I've got period pain, that's my lot in life, I'm a woman, and so I should just put up with it. And in fact, it took 4 years for her to be diagnosed with endometriosis. She was living on Nurofen. And then we look at the health professionals, and this is a woman who was aged 32, and the doctor told her, the problem nowadays is because you women take the pill, you don't really know what real period pain is. That's really, really insulting. And this woman took 19 years before she was diagnosed with endometriosis. So what is endometriosis? What are the myths that we want to dispel? One, that period pain is normal. The second, that pregnancy cures endometriosis, and that endometriosis only occurs in women over 30. These are myths that we no longer should be believing in. So tonight I'd like to talk a little bit about pathogenesis, prevalence, time to diagnosis, symptoms, the diagnosis, management, particularly in the adolescent, and then a short summary. So these are all members of the entertainment and arts industry who have had endometriosis. So what is it? Well, it's a chronic, inflammatory, estrogen-dependent recurring disease. In other words, we don't have a cure for it. It can impact on a woman's quality of life. It can impact on her ability to get pregnant, and it can lead to severe chronic pelvic pain. And in some women, that results in a surgical pelvic clearance and therefore a premature surgical menopause. And then that becomes another issue on how to treat a woman after she's had a surgical menopause with endometriosis. So what about the pathogenesis? Well, we really don't know. It's uncertain. We know that there are many factors, but there's also not just one disease picture. Endometriosis is not one disease. It is probably multiple diseases. The theory that has gained most kudos has been the retrograde menstruation theory. And you can see in this picture taken at laparoscopy during menstruation that the pouch of Douglas is filled with blood. But in the majority of women, that will happen, but the blood just gets absorbed and there's no issue. So we don't understand why it is in women with endometriosis that when that particular bleeding occurs, the endometrial cells don't get all mopped up by the macrophages, etc., but they stick onto the peritoneum, or they stick on to the tube or the ovary or the uterosacral ligaments, and they start to grow. And then there is new blood vessels. So there's angiogenesis. There is also the development of neural nerve pathways that come into those endometrial deposits. Why does that happen? We don't know. There are also other theories in relation to maybe blood or lymphatic spread, and also an embryological development, that's how it occurs. There's also evidence to suggest that maybe stem cells have a role in the development of endometriosis as well. We know that endometrial cells can actually deposit themselves in different sites. Classically, a woman who has a cesarean section who develops endometriosis in her wound site. And of course, we know that genes do play a part, and women have a 10-fold increase in the risk or the incidence of endometriosis if there is a first-degree relative present in the family. It's not a minor condition. 176 million women around the world are believed to have endometriosis, and its economic burden, as you can see here, is equivalent to diabetes, Crohn's disease, and rheumatoid arthritis. it is a significant condition in women. But of course, it only affects women. All of those other conditions affect men and women. The cost to the economies is massive across the globe. It's in terms of billions and billions of dollars in lost productivity, in illness, in decreased quality of life. It is a major, major cause of loss to the economy. Now, what's the prevalence? Well, it's thought that 7 to 10% of women in the reproductive age have endometriosis. A majority of women with chronic pelvic pain have endometriosis. Up to 50% of women who are infertile have endometriosis. And there is obviously the delay in diagnosis. And there are various studies around the world. The average seems to be about 7 years, but the younger the age of presentation of someone with period pain, the longer it takes to diagnosis, as in our case study. And those that report period pain and the onset of pain, it usually starts before the age of 20. So what could increase our risks? Well, having an early first period, having shorter cycles, women who have heavy and prolonged periods. So they're going to have more endometrial cells that are going to flow back into the pelvis. And as I've already mentioned, a 10-fold increase if there's a first-degree relative. Less risk if women have a lot of children and breastfeed for a longer period of time. And just similar to breast cancer risk, if women exercise more than 4 hours per week, there is a reduction in risk of endometriosis. So what are the symptoms? Well, there's not just one picture. Some people can be asymptomatic and never know that they've got endometriosis. Or it could be a variable pattern. It could be one day they might have one cycle, then they have one set of symptoms, another cycle it may be different. And it may be unpredictable. We may not be able to say this is what's going to happen every month. The main symptom is pain. But there can also be, of course, abnormal bleeding. There can be bowel and urinary symptoms. There can be infertility, as we've mentioned, and, of course, quality of life impairment. Now, pain is really the main symptom. And you can see here that 75 to 90% of women will present with pelvic pain or dysmenorrhea. And it's important when you take your history to note when the pain begins, what it's related to, whether it's premenstrual, and that's often a sign, or is it during the period? Is it both? Is it mid-cycle during ovulation? Is it during or after sex? Is it abdominal pain at other times? Is it associated with bowels, with opening the bowels or passing wind, or even urinating? And does it occur at ovulation? So the history of the pain is very important. That will give you some idea of whether it's endometriosis or it should be investigated for endometriosis. It can often be associated with heavy menstrual bleeding or irregular bleeding or prolonged bleeding or premenstrual spotting. Now, if there is deep infiltrative disease, then there can be symptoms related to the bladder or the bowel. So it can be bleeding if there is endometriosis that's actually gone through the bowel or bladder wall into the actual cavity, and so bleeding can occur at the same time as the menstruation. You can have irregular bowel habits, of course. That can be in many conditions as well. There may be associated with increased urinary frequency and changes in bladder function, which could be worse during the period. Sometimes there's an increase in the premenstrual-like symptoms, tiredness, bloating, irritability, depression. All of those things can take place in women with endometriosis. Yes, they're quite non-specific, but they can be part of that whole system and be part of the endometriosis. One of the things that's important in your history taking is to ask whether the young woman or woman misses any time from work, school, study, sport, whether they're able to function and to do their work appropriately, and also to look at what sort of medications they've been using. As in our case study, the analgesics that the woman was using, in fact, were not helping anymore. So taking time off and the symptoms progressing is really, really important to make note of. This will help you to determine that this could be endometriosis and that we need to do something about it. And of course, with chronic pain and severe pain, depression, anxiety, and distress all increase. Now, we've already said that 20 to 50% of infertile women have endometriosis. But why does it cause infertility? Well, of course, if you think about what endometriosis is, that it creates plaques and adhesions within the pelvis. And so it's to do with the anatomical changes that can take place by development of these endometriotic plaques and the occurrence of adhesions. But it also may be due to chemical products that are released by the endometriosis cells that somehow have an impact on being able to have an interference in implantation and even fertilization. And in women who also have adenomyosis, then that being a similar condition where you've got the endometrial cells growing in the myometrium, then there may be biochemical substances which will adversely impact on implantation and fertilization, and with adenomyosis, particularly in implantation. So we know that 50% of women will have endometriosis in women who are ovulating and where there is a normal sperm count. So people who come in with unexplained infertility, half of the women will have endometriosis. So I've already alluded to a thorough history being essential. And it's very important to look at the quality, the quantity, and the type of pain and where it is in relation to the cycle. So premenstrual pain is often a big giveaway that this woman could have endometriosis. So it's important to be thorough in your questioning and to also ask her to do a pain diary. We know that endometriosis is very difficult to diagnose, so a physical examination may not show anything. The only time you would find something abnormal might be where you've got some thickened uterosacral ligaments that you would feel in the posterior fornix, or you could feel an ovarian cyst, which could be an endometrioma. But then it would be deep infiltrated endometriosis. Endometriosis where there are plaques only and no increase in the destructiveness of the endometriosis, you're not going to be able to feel. Similarly, a vaginal or transabdominal, if a woman is not sexually active, will reveal absolutely nothing. It will be normal. That doesn't mean to say that endometriosis doesn't exist. It just means that it's not visible. What we do know is that we can see from the ultrasound whether there are any abnormalities in the uterus, ovary, whether there is any other reason that could be there causing the pain. In tertiary ultrasound, or gynecological ultrasound services, they can pick up evidence of deep infiltrative endometriosis, and also sometimes using a bowel prep before the procedure are able to determine whether endometriosis has actually progressed into the bowel wall or through the bowel wall. As I've mentioned, that psychological distress increases, so it's important to do a mental health assessment, all of which you are very knowing of. So it's talking about feeling depressed, feeling anxious, feeling tired, and how a young woman is feeling. Now, I've mentioned transvaginal or transabdominal ultrasound. So here we've got a picture which is showing, up here we can see that this is a left ovary with an endometrioma. And down here, we've got evidence of the serosa layer, and we've got evidence of a nodule passing through into the actual cavity of the bowel. And so we're able then to determine that this woman may in fact need not only a advanced trained laparoscopic surgeon, but may also need to have a bowel surgeon there when she's having surgery. Unfortunately, we've got no simple diagnostic tests. The gold standard for diagnosis is still laparoscopy. Laparoscopy with positive histology. Now you can see here that in this particular picture, there is endometriosis here. It is on the uterosacral ligament on this left side. It's involved with adhesions, with dense adhesions, the whiteness, and here we have a little blister of the endometriosis. Over here is probably a vein and not necessarily endometriosis, but you can see here, this is solid, a solid nodule of endometriosis. And here we have histological evidence in the specimen of endometrial cells. So laparoscopy will show you endometriosis, but it's important also to have positive cytology. Now, when we're managing a patient, it's important to educate, to treat appropriately, to monitor and counsel. And general practitioners and health professionals in rural and regional areas have a very important role in all of those aspects of management of a woman with endometriosis. So it's important to individualize the management plan, and it's important to discuss with her what you're recommending, why you're recommending it, so that you and she both understand what you're recommending should happen to her. So education is very important. Education for ourselves and education for our patients. These are some of the websites that are recommended, including our Gynaecologist website. We also have an endometriosis health professional tool for health professionals to guide them through the management of endometriosis. So education, education, education. What about management? Well, there are three goals. We want to reduce the pain. We want to manage the patient's pain so that she can function. We want to make sure that if she wishes to have pregnancies, that her pregnancy rate is maximized. And we want to reduce the delay, first in diagnosis, but also in recurrence for as long as possible. So delay the recurrence happening. So a multidisciplinary approach is the best way to go. And the linchpin of the multidisciplinary approach is the health professional in primary care working with the woman and then having all of the other people on the next layer outside of the two of you. Most important, and the one who should be in charge of what's happening and understanding and knowing exactly the management of each individual woman. Now, the management does depend on the age of the women, and I'm going to talk a bit about adolescent women shortly, because they really probably have a different type of endo, or it is different and they have different needs. Now, medical therapy is usually used post-operatively to suppress the endometrium so that we delay recurrence. Surgery is usually conservative and it is used to excise the known and visible endometriosis. And it's radical in women with chronic pelvic pain in whom recurrent endometriosis is there and doesn't seem to stop and become burnt out, as it were. And then, of course, there is the issue of chronic pelvic pain, and this is a different and difficult management for women in that particular state. There are special clinics. Jean Hales, we have a persistent pelvic pain service for women with such pain. Now, what about the medical therapies? Well, with our young woman aged 21, she would have possibly been prescribed the antiprostaglandins or the non-steroidal anti-inflammatories initially, and then she was put onto the pill. But what we find is that they're good, they're safe, and they're low cost. We could be using the progestogens, although Gynaecology we don't usually use here, but the levonorgestrel IUD or the atenogestrel implant, and in some cases GnRH analogues are used to suppress severe endometriosis either prior or after surgery. So surgery is really about conserving the reproductive capacity of women. And so we excise the area of endometriosis. The idea is to try and excise the endometriosis as much as is possible on the first surgery, so that hopefully further endometriosis can be suppressed for as long as is possible by using medical therapy. And I'll talk a little bit about surgical menopause and what hormones to use if women do have to have a radical clearance. Endometriosis surgery really requires quite a lot of skill and training to be able to get the feel for the size and the ability to be able to really excise the lesions safely. We need to, many of the trained laparoscopic surgeons have done advanced training so that they're able to excise quite large and major endometriosis. Most gynecologists are able to remove small lesions, but when it becomes severe, we usually need to refer on to an advanced trained laparoscopic surgeon. And we need to be able to diagnose the difference in the types of lesions, because if we look at the colours of them, you will have seen many pictures, and I'll show a few in a minute, of dark spotty lesions that look like they've got old blood in it, but sometimes they're red, sometimes they're white. And as I'm going to show you a picture shortly, in adolescence, we sometimes see that they are in fact clear and pale, and they can be like sheets across the peritoneum. So the idea is to remove the endometriosis, and it's important to have a referral base where you know that the gynecological surgeons you're referring to have a training and advanced training in laparoscopic surgery. So here we can see the classic dark patches of endometriosis. This is on the right side. This is the uterosacral ligament here, and here on the lateral pelvic side wall. This is probably over the ureter, and this is higher up on the lateral pelvic side wall. So this is very classic endometriosis. Here we've got a large nodular area in the pouch of Douglas that is sitting over the bowel with these great big plaques, and you can see quite a lot of adhesions pulling the tissue together. Here we've got a picture of adenomyosis. It's a soft, boggy uterus. And we sometimes see a soft, boggy uterus in women who have endometriosis, even at a very young age. And here we have an example of a very a large degree of endometriosis, a stage 4, where we've got the uterus adhered to the bowel. We've got a cyst here, probably on the ovary. We've got complete, there's complete loss of the pouch of Douglas, and the anatomy is completely distorted. And careful dissection needs to be undertaken by an advanced trained surgeon in this case. This is an endometrioma that's been opened up. The endometrioma was probably where it was stuck is down here, and when it's pulled off the tissue, then it will rupture, and then the actual cyst itself has to be removed. So not to just burn it, but to actually remove it. And that requires quite a degree of technique to be able to get that, remove the cyst wall and to leave the remainder of the ovary. Now, unfortunately, it's not a condition that is curable, so it does have recurrence. And the rates for recurrence are different in different studies, but it's thought that it's somewhere round about 50% by 5 to 7 years. And in the younger age group, it's greater. So we need to make sure that we can try and suppress the endometriosis so that women are not having recurrent laparoscopies too often, because it's every time they have any surgery, particularly where there's ovarian endometriosis, we are reducing their capacity for fertility with each surgical procedure. Now, what about the young gynae patient? So the patient that we, in the case that I presented, who first came at 17, which is probably reasonably late for a first presentation, but she is, she has gone to the GP 6 times. Now, when we're seeing a young patient, most of us would see the patient with their parent or caregiver, but then we would like to talk to the patient by themselves. And our senior laparoscopic surgeon at Jean Hales uses this head style of questioning. So looking at home and environment, what they know, what their education is, what their activities are in employment, what medications and drugs they've been taking, and about sex and sexuality, and then about mental health. All of these questioning is very important so that you're looking at a total person when you're trying to work out exactly which pathway to take. Now, the true incidence of adolescent dysmenorrhea is very difficult to quantitate, but you can see in this picture, oops, sorry. You can see in this picture that these are little, almost clear like little blisters. And often we see there's sheets of them. The whole of the peritoneum may be covered in these little blisters. So different from what you see in older women in their late in their early 20s and later. So red and clear, and they seem to respond more to hormonal management. So in that sense, using hormonal manipulation may be able to suppress endometriosis at an earlier age. So giving them a pseudo pregnancy by suppressing their pill, by using the pill, and perhaps using the pill continuously without a break, is a way of trying to create and help these young women. Excuse me. And it has been shown that pregnancy in adolescence sometimes leads to a regression, a significant regression of the endometriosis, but that's not really a good reason to become pregnant in adolescence. But once again, suppressing the endometrial cells is very important in this age group. So we're symptom-oriented in our treatments with adolescents rather than necessarily being surgically oriented in the sense of removing the endometriosis initially. So we would try the non-steroidal and anti-inflammatories, and then we would put them on the pill. Initially, we would put them on cyclic therapy, and if after 3 cycles they still have severe pain, the American College of ONG's recommendation is that they then should go for a diagnostic laparoscopy. However, it's possible in these young women, particularly if they're in the latter years of their schooling, in years 10, 11 or 12, then sometimes it's appropriate to put them on continuous combined oral contraceptives so that they're missing their period, and to see if that will suppress the pain and to delay any surgery until they've finished school. So post-operatively, once again, it's the suppressive therapy, as I've mentioned. Continuous pill under 16, usually continuous pill over 16, but we could use the Mirena, we could use the implant, and rarely we would use a GnRH analog or agonist in someone who has not reached their peak bone density. But it does depend on the degree and quality of the severity of the endometriosis. The youngest person I have been an assistant at the operation for endometriosis was a 13-year-old who was having her second laparoscopy for extremely aggressive endometriosis. So it's important to remember that it can start very early in adolescence as well. Now, what about the woman who's gone through a surgical menopause because of severe chronic pelvic pain and recurrent endometriosis? So what do we do? Well, it's not a lot of good data around to tell us what to do, but the Europeans recommend that we should use combined estrogen and progestogen therapy up until the expected age of menopause, around 51 to 52, or using tibolone because it can suppress the endometrium. The data, because it's not terribly good, in Australia, a number of women suggest low dose unopposed estrogen, but these women have undergone a surgical menopause, and so they're young and they will require high dose estrogen. And so therefore, in my opinion, it's appropriate to use combined therapy of estrogen and a progestogen that will suppress of a dose that will suppress the endometrium and improve and reduce their menopause symptoms. So in summary, the average of 7 years between symptoms and diagnosis. And why is that? Because I hope we've dispelled the myth that period pain is not normal, that endometriosis is not a disease of older women. Yes, there are non-specific symptoms that can overlap other conditions, in particular irritable bowel syndrome, and often they go together. Often we will see women with irritable bowel syndrome and endometriosis. We know that the physical examination is normal, so that doesn't exclude endometriosis. We don't have an easy test for endometriosis. and we need advanced trained or laparoscopically trained gynecologists, and most gynecologists now are trained at least to remove simple endometriosis. So it can occur at any time. We know that it's stimulated by hormones and the fluctuation of hormones and inflammation. We should be using empiric medical therapy to suppress the periods, to treat the pain, to treat early endometriosis, but also to try and inhibit disease progression. Now, it should be used in the adolescents, and the important thing is that it's not going to impact on their growth or their fertility. As I've mentioned, to refer for a laparoscopy if medical treatment is failed, and also early diagnosis is important and fertility is preserved. So very often fertility is enhanced in the first 6 months after an operative laparoscopy with excision of endometriosis. One of the things that, before I go on to this last summary, is that I have had a number of patients who have had endometriosis post-menopausally because of being on unopposed estrogen or even using vaginal estrogen in someone who has been also on combined therapy. So it's important, if there is a history of endometriosis up until the menopause, it's important to make sure that adequate progesterone is given post-menopausally. So in summary, endometriosis is a chronic, complex, heterogeneous, recurring disease. And there could be many different types that we don't know. We haven't got that classification yet. It's chronic and it's an inflammatory process. There is a genetic factor, and we still have a lot to understand about all aspects of endometriosis, about diagnosis, about treatment, and about how we manage women from the point of view of recurrence or fertility and pain. Thank you very much.
Thanks, Elizabeth. I do have some questions that have come in. So the first question is the average age of diagnosis in Australia.
Well, that's a tricky question to answer, but the average age of diagnosis is within about 7 years after the onset or the first presentation of period pain to a practitioner.
Next question, is pelvic ultrasound more accurate when it's performed at certain times of a woman's cycle?
That's a very good question. So it's not going to help endometriosis, but you get a lot more information from a pelvic ultrasound if it's done towards the end of a period or immediately after a period, so that the endometrium is at its thinnest and you're able to see the ovaries and the rest of the pelvis more succinctly.
Thank you. Is there evidence to support that hormonal therapy can be used in adolescents without impacting fertility?
The answer is yes. So using the oral contraceptive pill, either cyclic or continuous. Continuous if she still has period pain when the pill's used cyclically, it's not going to impact on her fertility. If she's got regular cycles, infertility is not going to be impacted upon at all.
And next question, the important role that pelvic health physiotherapy plays and when to refer.
Pelvic floor physiotherapy is appropriate in women with overactive pelvic floor, which may occur in women who have dyspareunia. If sex is painful, then they're going to tighten their pelvic floor. In women with endometriosis, the pain is usually deep dyspareunia. So the idea is really to treat the endometriosis first, and then if the treatment is such, then and the pelvic floor is overactive, then the pelvic floor physio would be appropriate.
Okay, there is no further questions at this stage. If you do have any questions, quickly type them in the questions box, and I'll just take this opportunity to thank Elizabeth for a fantastic presentation. Thanks so much, Elizabeth. That was so good. And we're so fortunate that you were able to present this evening. So thanks for your support, and also thanks again to Jean Hales for their involvement.
It's a great pleasure.
Another question, I'll just autoimmune link with the question mark. Autoimmune link.
I don't think we know. I don't think we have that research yet to say that it could be. You know, we know that it's familial, so there's a genetic aspect to it. Whether it has an autoimmune, it's a chronic inflammatory process, whether it fits into the autoimmune conditions, I don't think we know that yet. It's a very good question.
Thank you. Next question, do you have a preference with COCP? Which COCP?
Well, no, not really. I think that we would normally start with a 20 microgram pill in these young women. So one that is going to be effective in suppressing the cycle. If the 20 microgram pill doesn't suppress the cycle, then go up to a 30 microgram pill. Cost may be a factor. So depending on whether cost's a factor, whether there are any other issues or symptoms. So if somebody was to have also the possibility of polycystic ovary syndrome and endometriosis, then you might consider one that's got an anti-androgen in it. But all of those are not necessarily on the PBS.
Another question, there was a brief mention of naturopath involvement. Are particular herbal ingredients recommended?
Not necessarily recommended, but very often using some herbal remedies may be able to suppress some menstrual pain, and there are a number of other remedies that might be used, for example, with premenstrual-like symptoms as well. So it's part of the, you know, acupuncture might be used for pain. It's part of a holistic plan that you would make with each individual patient, depending on what her needs are and depending on exactly what her symptomatology and how you're going to manage her.
Question, do you do your own pain education with the patients? Do you refer to OT or pain clinics?
So I'm a bit lucky because when I've got women with chronic pain, I refer them to my colleague who runs our pelvic pain service. And there are a series of books. There's one very good book. If you'll bear with me a minute, I've got it written in a note here. It's called Taming the Beast by Professor Lorimer Mosley, and you can see it on YouTube. That's one of the recommendations from our clinic, and there are a number of books about chronic pain that I just don't have those in my head at the moment, but they might be on the website. They might be available in our book in the shop. but also to look in the pelvic pain service literature.
And another question, is there any evidence for acupuncture or herbal supplements such as evening primrose?
Don't think evening primrose oil has a role in endometriosis. The only reason why you would use it is if someone has premenstrual breast soreness, you might use it there. For premenstrual symptoms, you might suggest a herbal remedy called Premula, which is Vitex castus agnus, which has been shown in some short-term small studies to reduce premenstrual symptoms. But basically, it's really working with a team for what the needs are for the individual woman once her diagnosis has been made and what her ongoing symptoms and concerns are. And that's where you might consider using complementary therapies as well. For example, I sometimes work with a Chinese, traditional Chinese practitioner, and I might prescribe particular hormones and he might prescribe herbal remedies, and we work together to try and improve the quality of life of that individual woman. So it's about what works once the woman's been diagnosed and you've got to a certain stage in her management, and to then determine what other needs she might need.
Next question, is narcotic analgesia dependency an increasing issue in women with endo?
Only if you prescribe it. I mean, that's a bit trite, but basically if somebody's got to the endone stage, she hasn't been investigated and diagnosed properly, because she should have been investigated and passed on to somebody else before she gets to the endone stage. So she's a bit like the girl that I mentioned at the beginning, where fobbed off. You've got period pain, take this analgesia, take that. Don't do that. Investigate her for endometriosis. It's very important. Period pain isn't normal. It's very not normal. And yet women are still told in this day and age, oh, you're a woman, you know, get over it. Period pain's your lot in life. It isn't. It isn't. And I think it's very important that women shouldn't get to the stage of taking endone.
Next question, is there a role for CBD oil in the management of persistent pain?
I think that belongs to the area of the pain specialists, and it seems to be being used more and more now for chronic pain. And chronic pelvic pain is one of the types of chronic pain.
Another question, having to start estrogen therapy at a young age due to a hysterectomy because of endometriosis, total hysterectomy, can endo be found in other parts of the body or traces of? Have you heard this can happen? Yes,
there very rarely do we find endometriosis in other organs, and it's not necessarily coming from the pelvis, but it may develop de novo, for example, in the eye, in the lungs, other places, but it's extremely rare.
Next question, are young women who don't want to go on the oral contraceptive pill supported if endo is suspected or diagnosed? Can they achieve quality of life by implementing other strategies?
Well, the problem is that to suppress the endometrial tissue, they need to have some type of medication that's going to do that. And really, hormones are primarily the way of doing that. Now, if that person is absolutely adamant that they don't want to go on any hormone product, then this is where you might consider getting the traditional Chinese doctor to see whether herbal remedies might help her. But she's not going to be suppressing the endometriosis, so she's at greater risk of recurrence.
Now, this is not a question, it's just a statement. There's a book, Why Pelvic Pain Hurts, by Adrian Lau, ADRIAN-LOUW.
Okay, good. All the more books, the better.
Yes.
The more
exactly.
education, the better for all of us.
Thank you, Elizabeth. That looks like the end of the questions. Just for our participants, please don't forget to fill out your evaluation. Jot down the topics, any topics at all you want us to present, that'd be helpful. Our next Jean Hale's presentation is on a menopause series, so that is being organised as I speak. That'll be in the middle half of the year. And we also have our emergency series. Our first one is 11th of March, paediatric, followed by obstetric emergencies, followed by cardiac emergencies. So keep your eye on the website for those. I will finish off here. Thank you, Elizabeth. It's been a pleasure having you this evening. Goodbye, everyone.
Thank you very much.